Episode 1, Dermatology Essentials for USMLE, Step 2, CK. Welcome to Master USMLE, the podcast where we break down high-yield medical concepts in a way that sticks. I'm Dr. Amina Frasiabi, and today we're diving into dermatology for USMLE Step 2 CK. Whether you're listening on your commute, at the gym, or during a study break, this episode will give you everything you need to crush the dermatology questions on your exam. Let's get started. When it comes to dermatology on Step 2 CK, vascular tumors come up a lot, and they're easy points if you know what to look for. Let's start with cherry angiomas. These are those tiny bright red papules that show up as we age. They're completely benign, don't go away, and tend to increase in number over time. The key takeaway? They do not regress. That's in contrast to strawberry hemangiomas, which are seen in infants. These appear within the first few weeks of life, grow rapidly for the first year, and then start shrinking. By the time the child is 5 to 8 years old, they usually disappear completely. This is one of those questions where you don't even need to read the entire vignette. If you see a child with a red, raised lesion that's growing but is otherwise healthy, think strawberry hemangioma. If it's an adult with tiny red papules that have been gradually increasing in number, cherry angiomas are your answer. Another vascular lesion to know is Kaposi sarcoma. Now this one is a game changer because it's not benign like the others. It's caused by human herpes virus 8, and you'll see it in patients with HIV or other immunocompromised states. It presents as red or purple plaques, typically on the skin, but also in the mucosa. If you get a vignette with a patient who has multiple dark violaceous skin lesions and a history of HIV, start thinking about Kaposi sarcoma. There's one more condition that looks similar: bacillary angiomatosis. This is caused by Bartonella henselae, the same organism behind cat scratch disease. The tricky part? Bacillary angiomatosis and Kaposi sarcoma look alike, but here's the giveaway. Bacillary angiomatosis has a neutrophilic infiltrate, while Kaposi sarcoma has a lymphocytic infiltrate. So if the question gives you a biopsy report, pay attention to what type of cells are in the infiltrate. All right, let's move on to blistering skin diseases, one of those high-yield testable topics that you can't afford to miss. There are two conditions you need to know: pemphigus vulgaris and bullous pemphigoid. Pemphigus vulgaris is the more severe of the two. It's caused by IgG autoantibodies against desmoglein, which is a component of desmosomes. Those are the structures that hold keratinocytes together. So when they're damaged, the skin layers start to separate. The result? Flaccid bulli that rupture easily. You'll also see oral mucosal involvement, and here's the classic test question: Nikolsky sign. That's when you apply slight pressure to the skin and it sloughs off. If Nikolsky's sign is positive, you're dealing with pemphigus vulgaris. Now compare that to bullous pemphigoid. This is caused by antibodies against hemidesmosomes, which anchor the epidermis to the basement membrane. Because the separation happens at a deeper level, the blisters are tense, meaning they don't rupture as easily. There's also no oral involvement, and Nikolsky sign is negative. So if you see a patient with large, intact blisters on the skin and no oral ulcers, you're likely dealing with bullous pemphigoid. One last thing to remember: treatment. Both conditions are treated with corticosteroids, but pemphigus vulgaris often requires more aggressive therapy, like rituximab or Ivig. Next up, let's talk about pigmented lesions and skin cancer. The most important one for the exam? Melanoma, and the easiest way to recognize it? The ABCDE rule. Asymmetry, border irregularity, color variation, diameter greater than 6 millimeters, and evolution, meaning it's changing over time. That last one is a big deal because any pigmented lesion that's growing or changing should raise suspicion for melanoma. Melanoma prognosis is based on one thing: Breslow thickness. The deeper the lesion, the worse the prognosis. That's why early detection is key. If the question asks about the most important factor in prognosis, the answer is always Breslow thickness. Then we have basal cell carcinoma, the most common type of skin cancer. The classic description is a pearly, rolled border with telangiectasias. These lesions are slow-growing and rarely metastasize, so they have an excellent prognosis. If they give you a vignette with a painless, slow-growing lesion on the face or neck, especially in an older patient with a history of sun exposure, think basal cell carcinoma. Squamous cell carcinoma, on the other hand, is a little more aggressive. It presents as a scaly, ulcerated plaque and is more